Hello and warm welcome to MedSynapse podcast series where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host Dr. Smarika Bhatt and today we are diving into a condition that affects millions but rarely gets the spotlight it deserves, that is hemorrhoids, or they are commonly called as piles. To talk about more deep about this topic, we have been joined by the pioneer Dr. Gaurav Gangwani with us, an interventional radiologist performing groundbreaking minimally invasive procedures for hemorrhoid treatments. Dr. Gangwani has trained at some of the finest institutions in the country and bring expertise from international workshops and conferences in New Zealand, Japan, and America. Welcome, Dr. Gaurav, to the podcast. We're excited to have you here.
Thank you so much. Pleasure to be back at MedSynapse platform to create awareness.
Thank you so much. It was an honor to host you again for the second time for a lovely next topic for our audience. So, without further ado, we'll jump right in with our first question. Many listeners will be familiar with traditional treatments like rubber band ligations or hemorrhoidectomy, but might be surprised to hear these don't always work in our clinical practices. So, in your experience, what arterial patterns predict hemorrhoidectomy failure but respond well to embolization?
So, very interesting question. To answer that, I'll just start with a short background. Many of the viewers might be wondering on that the gold standard for hemorrhoid surgery, the gold standard for hemorrhoid treatment has always been surgery. Different types of surgeries, hemorrhoidectomy, rubber band ligation, recently introduced DGHL. But what is this embolization and how does it play a role in hemorrhoids? And why this tall claim that it can even treat patients with recurrent hemorrhoids and the chances of recurrence after this treatment is much lesser than surgery. So, our concept of hemorrhoids changed almost 3 decades back. Before that, it was always believed that hemorrhoids are ectopic anorectal varices, dilated varicosities. But soon, many authors proved that they are actually submucosal anal cushions made of submucosal dilated vascular mesh, capillary mesh. And when these cushions expand, due to it is known as sliding anal cushion theory, they can prolapse eventually and cause hemorrhoids. And it is because of the soft tissue, the extracellular matrix, sort of inflaming and with neovascularization that this occurs. It's not actually varices. Uh, During that time, there was a very recent paper by Agner et al., where he showed that each hemorrhoid is supplied by arteries, which are actually branches of superior or middle rectal arteries. You can call them hemorrhoid feeding arteries or hemorrhoidal arteries. And the flow in these arteries is much more exaggerated than a normal person. So the velocities are higher, the flow is turbulent. So he realized that there is increased neovascularization and feeding flow to the arterial flow to these hemorrhoids. Second, he noticed that even after surgery, when the hemorrhoidectomy is done, the flow in the feeding artery is still the same. It is still increased. And that is what is sort of a predictor that the hemorrhoid can come back because the neovascularization and the increased flow is still persistent despite surgery. You have removed the hemorrhoid, but the flow being persistent can again lead to the hemorrhoid now, a recurrence of the hemorrhoid now. So that is with this concept in mind. Uh, and of course, lastly, before I proceed, he also showed a third aspect that those who have higher flow have higher grade hemorrhoid. So any person with a higher systolic velocity will have grade 3 or 4 with hemorrhoids, whereas someone with a moderate increase in velocity may have grade 1 to 2. So with this hemodynamic understanding and concepts in mind, there was a famous surgery invented which was known as DGHAL, Doppler guided hemorrhoid artery ligation, where the experts said that instead of removing the hemorrhoids or laser ablating them or rubber band ligation, all you need to do is just under rectal transrectal Doppler guidance, just ligate or suture these feeding arteries. And if you do that, you occlude the feeding arteries, the hemorrhoid will naturally shrink and the chances of recurrence would be lower. And when compared in studies, articles, and head to head with hemorrhoidectomy, they found that the results are excellent. Even the short term results are as good as hemorrhoidectomy. The recurrence is much lower. And finally, the post op morbidity is much lower because you are not doing a hemorrhoidectomy, you are just ligating with the suture. overall pain in the follow-up period was much lower, lesser morbidity and early return to recovery. So based on those data right from 3 decades ago, the hemodynamic pattern that would predict failure is persistent high systolic velocity and turbulent biphasic flow or even monophasic pulsatile flow in the hemorrhoid arteries. That would predict failure, and if that's the case, I would definitely go for GHL or now embolization, where we can go endovascular through the wrist, taking a tiny microcatheter 1.9 Fren, 0.4 millimeters, and put a coil inside the hemorrhoid artery and just cause complete regression of the piles or hemorrhoids without having need to do any surgery, not even removal of bands.
Okay, that was really insightful, Dr. Gaurav. So, moving on to the next question, walk us through the protocols for selective hemorrhoidal arterial embolization and what embolic agents do you prefer and how do you determine the particle size?
Yeah. So, as a prerequisite, before selecting hemorrhoid artery embolization, we of course let the patient undergo the standard proctoscopic examination and grading of the hemorrhoids. We have been able to offer this treatment for grade 1 to 3. Usually, we reject grade 4, that is prolapse that is not receding even on attempt. So, we only do it for grade 1 to 3. At least reducible prolapse should be there, not irreversible prolapse. That's one selection criteria, main criteria. When we do the procedure, the patient comes in as a daycare patient. My protocol is transradial. Some operators prefer transfemoral. We just take a tiny puncture with a 5 French sheath, which is again around less than a millimeter plus in diameter, and we take a small diagnostic catheter into the superior rectal artery mostly. We take a angiogram. If we see that that artery is supplying the hemorrhoids, we inject a few particles. The average size is around 500 to 700 microns, some cases 700 to 1000 microns. And immediately we coil the feeder branches of the hemorrhoids. So this entire process is hemorrhoidal artery ligation. Now the embolic agents, my go-to embolic agent is something that most of the world follows, and it's a combination of particle and coils. Even hemorrhoid centers in USA, a famous center with one of the largest publication and largest series of treating hemorrhoids, they have been doing something similar. So, and their results are phenomenal, almost 92 to 96% cure rates in 134 long patients, and rest of the patients second session cure. So almost a near promise of complete cure. And so my particle size is around 500 to 700, selected patients 700 to 1000 microns, and it's a combination of particles and metallic coils. Once I take the angiogram, if I feel there are non-target supply or there is a feeder coming in from the middle rectal artery, then I may increase the number of particles, or I may take actually an internal iliac and a middle rectal run to ensure that I'm doing optimal embolization and chances of recurrence are less. But yes, that's the usual protocol. Post embolization, patient has a TR band, a short bracelet on the hand for pressure, and within 2 hours, patient can walk home. Like I said, it's a daycare procedure. There's no sedation, everything under local, so patient can have their meals immediately and walk home.
Okay, so that was a very well put together answer. So we'll move on to the next part is what specific hemorrhoid dynamic metrics guides you embolization endpoints and how do these relate to patient's outcome?
So, like any other embolization, our embolization endpoints are pretty similar. We look for two things. One is the blush, which in our language is labeled to the vascular capillary opacification that we see on X-ray once we inject the dye and wait for a few seconds in the artery. So point is, when we begin and we inject dye in the superior rectal artery, we see the feeder arteries. Then we see a delayed capillary phase where we see the hemorrhoid actually enhancing and opacifying. And then we see the venous filling or venous opacification. So that blush, we want it to disappear. So the particles would ensure that. And then to prevent a recanalization because of the feeding arteries, I will put coils in the separate feeding arteries that are supplying the hemorrhoid. So disappearance of blush, one, and occlusion of the feeder arteries, superselective feeder arteries, which stasis in the non-selective proximal feeding arteries, is the second endpoint. These are the two common endpoints that we look at embolization. And for hemodynamic matrix, we don't measure it immediately, but on follow-up, we may actually do a transrectal Doppler and check the flow in the superior rectal artery, just to be sure that besides clinical success and disappearance of the pain, swelling, prolapse, itching, etc., bleeding, we have also ensured radiologic success, and on Doppler, the flow is nearly negligible in the feeder arteries. So with these two endpoints, we are very sure that we are not going to have recurrence.
That was a wonderful insight as you have touched upon the real-time incidents. So let's move on to the next question is how many, there will be many of the patients who have tried multiple treatments before coming to you. So how do you assess and manage vascular changes in patients with recurrent hemorrhoids post-surgery?
Yeah. So first is we would like to get the detailed surgical notes and find out what kind of surgery was done. Was it a rubber band ligation or a hemorrhoidectomy and a complete hemorrhoidectomy, or was it a digital Doppler guided hemorrhoid artery ligation? And finally, nowadays laser ablation is becoming a trend. So yeah, so we try to find out in detail what kind of surgery was done. That helps us a lot. If it is a just a laser ablation, we know we are dealing with almost a complete recurrence of anal cushion. Vis-a-vis where it's a hemorrhoidectomy, we try to understand why the recurrence occurred despite removing the whole anal cushion. Is it a prolapse in a different location by a different anal cushion, and what's going on? So first is we try to navigate through the operative notes and find out whatever we can about the surgery done and if there was any suboptimal surgical step left. Next step, again, like I said, we do the transrectal Doppler. We try to understand if the hemorrhoid arteries are still intact. Finally, most patients we would prefer doing a CT angiography or a MR angiography, depending on the institute and the availability and resourcefulness. So most of the times it is CT angiography, uniform and easily available, cheap. And we see what went wrong and which arteries are supplying it. Is it the superior rectal artery or the middle rectal artery? All the more important if we are dealing with a failed or a recurrence after DGHAL, Doppler guided hemorrhoid artery ligation, then this becomes important. And even before starting the embolization, we know that the arteries are ligated, but maybe middle rectal artery is causing a recurrence. So we can now, instead of wasting time the superior rectal artery, which is usual protocol, we can target the middle rectal artery. To just summarize, we would do a simple transrectal Doppler, we would go through the operative notes, and most cases we might do a CT angiography, especially in failed surgical cases.
Dr. Gaurav, so as we all know, case safety is obviously a paramount. So what's your approach to managing embolization specific complications and how does it differ from surgical complication management?
So, the most common complication post surgery is severe perioperative morbidity and actually immediate post op period morbidity. And there, despite giving stool softeners and painkillers, it is for anyone who has undergone a pile surgery, especially a hemorrhoidectomy, it is not a sweet period to bear. It is very morbid. Patient, although the surgery is done, technically the patient can start work the next day and come for suture removal after a few days. But every patient knows that it is difficult to resume work because even their gait is not normal. It is that kind of painful and morbid. Uh, Compared to that, and of course, depending on the surgical complications, it can range from infection to bleeding and so on. But vis-a-vis to that, embolization, to be honest, we don't have much uh, moderate complication rate. If at all, any complication, it's usually mild and pretty controllable. So at the max, what we would experience is mild post-embolization syndrome. Patient will have very mild reactive ischemic pain in the hemorrhoidal area, some thrombophlebitis of the hemorrhoids because they are not getting the feeder arteries, so most likely they are clotting and eventually shrinking. Most of the times, all we need to manage this is simple, I would say, simple analgesics that also not very potent, low dose ones are also okay, including paracetamol or opioids, mild opioids. And we sometimes add laxatives just to make it easy for the stool to be soft so that uh, at the max, if we have any puncture site complications like a small groin hematoma or a wrist swelling, that can be just managed with compression. So, and again, I'm just labeling all of this with this for the sake of completing the list of complications. Practically, it is just mild post-embolization syndrome, which can be managed with simple analgesics and so stool softeners or laxatives. And besides that, we have not really faced many issues in regards perioperative or post-operative complications. So patients are, much more happier with having a surgery or a minimally invasive alternative where they don't even need to remove their pants. Imagine dealing with piles without having to do that. And a post-operative period where actually practically the patient starts work the next day, and no one from the gate can understand that the patient has undergone this intervention, of course scarless. So yeah, practically speaking, real world scenario, the complication rate is nearly negligible and does not require any management whatsoever.
Okay, that was perfectly explained, and thank you so much, Dr. Gaurav, for bringing in such a detailed treatment plan for our listeners. And thank you to our viewers for tuning in. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with the medical peers or participate in meaningful discussions and contribute to the ongoing evolution of healthcare. So until next time, stay tuned, take care.